Hi, thank you so much for joining us for our webinar on patient cases. I'm Rachel Krug, the CEO of Virtual Field. Virtual Field is an exceptional eye exam experience with visual field, color vision, and pupillometry exams in a comfortable patient-friendly headset. We have Dr. Hall and Dr. Raymondi with us today to present their patient cases with Virtual Field. If you could each introduce yourself, that would be great.
Yes, hello. My name's Dr. Hall. I'm one of the optometrists here in Indianapolis, and I'll be going through a glaucoma case with you guys.
All right, and hi, I'm Dr. Raymondi. I practice optometry in New York at Metropolitan Hospital, and I practice sewer eye care in Jackson Heights, Queens, my hometown.
Awesome. Thank you both for joining us today. We will start out with Dr. Hall's patient case. Dr. Hall, take it away.
All righty, I will go ahead and get my screen up here. All right. And awesome. So like I said, I'm going to do a glaucoma case with you guys. I work for a predominantly cornea practice in Indianapolis. However, we do see a lot of glaucoma, or glaucoma does come up due to transplants, frequent steroid response, and all that kind of stuff. However, my case today has nothing to do with transplants. It is all about the glaucoma side of things. I saw this patient originally with a surgeon about a year and a half ago, but he's in continued care with me. And he actually came to our office complaining of blurry vision after a YAG cap was done. He had been getting worse progressively over the last 4 to 6 months. We didn't quite know what was going on. He really didn't have much of a systemic or ocular history that he really disclosed, nor did he actually have. He really didn't have much going on. As you can see, I listed here any pertinent things, but honestly, a lot of it's not. We asked him a lot of questions about his cataract surgery, and everything went smoothly. He had a YAG done in 2021. The only thing that he did notate as far as like what's related somewhat to the eyes is just some occasional ocular migraines, but he hadn't had one in a long time from what he told us, which we believe to be true. His other medical history was just shingles. He had hearing aids and a little bit of arthritis, but it was all very controlled. He did not take any medications, just did artificial tears for the dry eye that his doctor told him to do after his YAG cap. When we did his initial workup, you can see his vision's actually pretty good, 20/25, and both eyes individually. Pressures are what we thought were within normal limits at 20, but this was at 3 o'clock, so a little bit on the high side, but again, still nothing that makes you really panicked about what you're going to be seeing. General slit lamp exam was perfectly clear, just again had those IOLs, which he had disclosed his cataract surgery with open capsules. We then moved on to doing his fundus exam, and these were his optic nerves. And so obviously for someone who didn't have a lot of history, really didn't have any complication after surgery, really no complaints. He did say he went to get his eye exam every year. It was done with someplace who did just fundus photography, but he said he had continually gone and they never told him he had any problems. This concluded our first visit. We obviously started him on an IOP lowering drop, and I'll kind of get to his regimen here in a second. And we wanted to bring him back quickly to do a virtual field, just because, again, as we all know, when we kind of get into these lower numbers, we're worried about how much we can really rely on the OCT. Is there more damage? Is there more than what we're really seeing here with the general scan? So 2 weeks later, he comes back, and unfortunately, this was his starting virtual field. And so I just want to take a second to even pause and talk about obviously what we're looking at. Here you're seeing what we had with our headset for virtual field, and you are getting all the same values that you would expect to, obviously, with the field, even though we did it with the particular headset. This was the first time the patient had taken it. Looking here, you can obviously see we are super out of bounds as far as where his normative value should be. He did have some false negatives, but as far as fixation losses and timing to take the test, you can tell it was really reliable for both the right and the left eye, even though, again, this was the first time he'd ever done this, and we're using it pretty much for how we're going to treat him moving forward. In cases like this where you're seeing such severe nerve loss, I am just so grateful that we do have the headset, because again, with this patient's demographic, he was 87. Even though he didn't have any health problems, it was so much easier for him to navigate the testing because of the instructions. And again, having a little bit more guidance as far as showing the prompt, showing the lights, different things like that. He said it was pretty easy to take. And again, we can really take it for face value because of all the things I was able to analyze through just his first initial visual field. At this time, especially when you're seeing field blasts like this, you know that in any glaucoma case, you really need your fields to be accurate. And so even though this was his first test and we did feel like he did it well, we did bring him back to do a repeated test. And I'll kind of show you, or I'm going to spend the bulk of my time talking is actually on this slide, where we actually are looking at his progression analysis. So on that side of your screen, you're kind of seeing the breakdown of his visits. So when we did this first particular field, this was actually the visit before then. We had just looked at the optic nerves. And again, with IOPs being 20, the particular surgeon that he saw placed him on just one single drop to use at night to try and bring down the pressures because we weren't quite sure how much vision loss he had attained. Once we saw this first visual field taken and how much peripheral vision the patient had lost, we went ahead and added bromonidine along with the latanoprost. So he's now taking 2 medication drops to maintain, and just to maintain his pressures and get it as low as we possibly can. For this patient, our IOP goal, we want truly less than 12 just because of how much field loss that he's already experienced and unfortunately has gone unnoticed for who knows how long. His third visit here with us, we did repeat the field just to be certain. And you can see that, I don't know if my clicker actually shows up on your guys' screen, but the second field down is when we brought him to repeat the field after he had been on the 2 new drops. And weirdly enough, he actually did a little bit better on the left. But we can see that the right eye, that field loss is still so limited. He's really just got an island of vision. And and even though the left eye was better, obviously we can still appreciate that he's got some severe glaucoma going on. With that being said, we rely so heavily on the visual field that this is the test that I really am using even still to know whether or not he's changing or if he's getting, if he has more progression than obviously what we're monitoring. At the time, when we repeated that test on April 27th of 2022, if you can see the date there on the side, because the right eye did look a little bit worse and we were just a little bit more worried about it, we went ahead and added again a third IOP lowering drop. We tried to do a combo because the patient's 87. However, insurance is tricky with that. So added him on his third drop. And thankfully, he remained stable for almost a full year with visual fields, with OCTs, with checking IOP until about a year later. So the fourth bullet down, it shows that IOP remained stable under 14 until October 2023, where at this point you can see his field is down there at the bottom, where that left eye, the patient's really got a better understanding. I should have put the individual print on here for you, but you could see that again, the test was more than reliable. He had no fixation losses. Timing was about the same, but the field continued to progress. And so we at that point recommended him to have an SLT so we could avoid hopefully more drops, but then we were able to get a combo drop approved for him. But I pretty much put him on max meds. This was when he was transferred over to my care, and we could see that this is a really progressive form of glaucoma. And so his drops are listed there at the bottom. I had swapped him to COSAP, bromonidine, and Rocklatan just to really max him out and hopefully never, repeat the field and see progressive loss. He did have his SLT. His pressures have remained under 14, which his are almost always now like somewhere between 8 and 12. But the reason I really presented this case was just to show really how much of a utilized tool that the virtual field headset has become for me. With cases that are so severe where you are watching progressive field loss so closely, I just feel like there's no better way to track, again, an elderly patient who has a harder time taking tests, has a hard time hearing, than with something like this that's really reliable. I can get him to focus and fixate and really adjust the headset to where he needs it to be, and also really try and prevent him from having any more field loss than he already does. Funny enough, he is coming in next week to see me to do a repeat visual field. His one that he's done most recently, he did one in March. It looks pretty much identical to the one on October 27th, so I didn't put it on here because I felt that the progression analysis really showed kind of where we were at, and again, why we're relying so heavily on the on our field really to control his glaucoma. So with that pretty much concludes my case as far as showing what the field can do, but I'm happy to answer questions or talk a little bit more about this particular case if you have questions about his sequence or his changes.
I don't see questions. Let's move on to Dr. Raymondi. Thank you so much, Dr. Hall. That was great.
And I'll stop sharing here. Thanks.
Right, there we go. That progression analysis was beautiful, Dr. Hall. I loved it. All right. So this is my virtual field case study, and my name is Dr. Damaris Raymondi, and let's get right into it. So I had a 67-year-old male with a history of transient ischemic attack that happened in 2007, and he presented for an evaluation of a long-standing visual field defect. In his own words, he told me that he cannot see when someone is approaching him from his right side. And this TIA from 2007, as per the patient, didn't have any known cause. He didn't have diabetes, no high blood pressure, no other cardiovascular things, no recreational drug use. Everything was within normal limits. And luckily, the patient had a complete recovery except for these constant visual field defects. He's not on any current medications. Pupils, color vision, and EOMs were within normal limits. And confrontation visual fields in the right eye, he was unable to see the fingers in the superior nasal quadrant, and in the left eye, unable to see it in the superior temporal quadrant. Now, show of virtual hands here. Who here does confrontation visual fields on every single patient that comes in? I will be the first to admit that I don't do it on every single patient. I'll do it on a new patient who ends up complaining about a shadow or ghosting, or they have decreased visual acuity, and that's when I'll do it. And whenever I do confrontation visual fields, it's amazing how much it correlates with computerized visual fields. So with this patient, anterior and posterior exam were unremarkable. And luckily for us, this patient brought in their visual field from August 2015. This is a carbon copy, so let's try to zoom in here and look at the reliability indices. But while I'm doing that, can you all think in the audience, what would you identify as the pattern of this visual field? What pattern is this, if you want to put it in the chat? So this is a central 24-2, fixation losses in the left eye, 2 out of 12, false positives 12%, false negatives 18%. Let's go over here to the other eye, fixation losses 0 out of 12, false positives 1%, false negatives 20%. Let's go to the visual field indices for the glaucoma hemifield test. For both, it was outside normal limits. VFI 67%, here 70%. And mean deviation minus 11.8, minus 9.7. Pattern standard deviation 14.8, pattern standard deviation 12.2. So when this patient came in January 2023, by then I had a virtual field headset, the VF3 model, and we ran a 24-2. And now looking at this, where do you think this lesion is located? You can answer out loud or put it in the chat if you'd like. So there you go, have a look. Fixation losses, 0 out of 8, false positive 0%, false negative 0 out of 9. And then here in the right eye, oh, where am I? There you go. Fixation losses 0 out of 8, false positives 1%, false negatives 0 out of 8. And it's way clearer, the visual field indices. 63%, -9, 11, and -5.9, -8. All right, let me try to do this here. So I'm just gonna go back to this. Okay. So the first visual field was taken in August 2015, and then the visual field was done the second one was done in January 2023. So what we have is a right superior homonymous quadrantinopia, or a pie in the sky visual field defect. And its congruous defect localizes to a retrochiasmal visual pathway. And this lesion is in the left optic radiations coursing through the left temporal lobe. And the most common cause of this is an ischemic stroke. So here I have the top from the tabletop perimeter up here, and then in the bottom, I have the virtual field. So unfortunately, with this kind of lesion, it cannot be treated with prisms. It can be treated, excuse me, let me go back. It cannot be resolved. It's going to be a permanent visual field loss. We can treat it with prisms to shift the visual field, or we could do TBI type visual rehabilitation therapy. And that way we can draw awareness to the area that the patient needs. And we can also monitor with serial visual field. And if the patient develops other ocular diseases that impact the visual field, we know where this patient's baseline is and that it's been stable for 9 years. So why is this important? This is important because when I first was deciding on getting a visual field for my practice, I didn't think I would get one because of the cost, because of the size. I wasn't sure. And when I was thinking about a virtual field, I was thinking, okay, what's the reliability going to be? Is it really going to be true to the tabletop perimeter? But when we look at the comparison between these two, the reliability indices are so much better in the virtual field than in the tabletop perimeter. And point by point, looking at each plot, we can see how it correlates perfectly. 9 years later, this patient is completely stable. So a quick review about the different virtual field maps. Total deviation, that tells us about the deviation that lands outside of the range of normal sensitivity. And then the pattern deviation, it tells us it's the most useful map that we have, and it tells us about the statistical significance of defects, their location, and shape. This is a review on the glaucoma hemifield test. It's super easy. It tells you outside normal limits, borderline, within normal limits. And it detects everything with high sensitivity and high specificity. VFI, when you get 100% value, is normal vision. 0% means it's parametric blindness and that the patient can't even see the brightest stimuli. Mean deviation, when you have 0, that means that there's no deviation from normal. And a large negative value is associated with advanced field loss. With pattern standard deviation, you have a low value in normal fields that are uniformly depressed, and blind fields. And you have the highest in moderate to advanced localized loss. And I use this a lot in the Oates calculator. Who here uses their Oates calculator? I use it all the time, and I don't necessarily rely on it, but the way that I utilize the Oates calculator is when I have a low risk patient, and let's say the calculator shows up as 10%, then I might delay seeing them for like 6 months or even a year, 10% like likelihood of progression. Versus when it's a 33% likelihood or a 40% likelihood, I'll have them back more frequently. So thank you so much. If you want to say hi, this is where you can find me. And if you want to find out the identity of this patient, you can either email me if you don't have Instagram, or if you can check out my Instagram stories, and I'll let you all know there. Thank you. Any questions, type it up.
Awesome. Thank you so much, both. We really appreciate Dr. Hall, Dr. Raymondi. Thank you so much for the case studies. Appreciate your time, and we're gonna wrap up.